Everyone. So this is Peripheral from Philadelphia, and I am joined by my friend Emilio, who is in Boston. And today we are happy to welcome back Dr. Rodriguez. He is going to continue his neuropath lecture series. And today's topic is hematolymphoid and secondary tumors of the CNS. And thank you, Dr. Rodriguez, for joining us. As always, please feel free to post your comment or questions on our Facebook chat windows as well as YouTube windows. We will be happy to pass them over to Dr. Rodriguez, and he would answer them at the end of the session. Over to Dr. Rodriguez now. Thank you so much.
All right. Well, it's a pleasure to be with you again with another CNS topic. This is, as I prepare this presentation, I noticed that there's a lot to cover normally, so it will not be able to cover everything that you need to know about this topic, but I will show some illustrative examples from my experience that I think will be helpful to approach these problems in general. So actually, we can go straight to the cases. The first case is a 76-year-old man with a right parietal lobe mass. And this is the slide, and you can see you can gather that this is a stereotactic needle biopsy, which for many of the hematolymphoid proliferations in the CNS, you're going to have to deal with. So something to have in mind, that tissue may be limited. And for many of these biopsies, you may be stuck with very little material. And remember that if you're in the intraoperative setting, doing smears will be very helpful. In this case, you do see an increase in cellularity. You can argue that there are also some reactive astrocytes and other mixed cells. But I think if you have previewed the slides, that these are the guys that are really piquing your interest. It's a patchy process here. And you have it here as well. And of course, you have a differential. But I think when you start seeing areas like this, what is really, even being patchy, something that catches your attention is that you have these atypical cells surrounding vessels and areas. In other areas, you see more of a sheet-like type of growth with a mixture of cells. But certainly these cells do not belong there, right? And in some areas like this really should raise your suspicion if you see it. You have these cells, this cuff of cells that are really larger than your typical perivascular lymphocytes. So this is concerning. Here are more areas in which you have more patchy involvement. But again, the angiocentric pattern is very typical of this. It's important, something to really have in mind. And of course, if you had to do one stain, it will be CD20. And this, you have it here. You can see much more cells than you see with the H&E that are large and strongly CD20 and uniformly CD20 positive. So we have a diagnosis here. Diagnosis is involved by large B-cell lymphoma, which is going to be the most common lymphoma that you see involving the CNS primarily. So, and I like to say many times involved by large B-cell lymphoma, particularly in small samples. And of course, the wisdom is that parenchymal involvement in the CNS is usually large B-cell primary CNS lymphoma does that. Secondary involvement by systemic lymphoma usually takes the form of leptomeningeal or superficial dissemination. Those are some broad concepts that you see that in most cases are true. You do have exceptions both ways, but that's usually how this happens. So what is different about large B-cell lymphoma involved in the brain? We do very little in the way of characterization with immunophenotyping because they tend to be of the activated type, but the distinction between germinal type and activated type is not as critical, and it has no prognostic significance in primary CNS lymphoma. So the important thing is to document, to see it, document that it is CD20 positive, and we'll see some examples also exclude that EBV is a culprit, particularly in immunosuppressed patients. So those are the main things that you have to know about primary CNS lymphoma. There's several, as in many other hematolymphoid tumor literature, there's a flurry of papers in the past several years documenting the genomic landscape of CNS lymphoma. And what has come out is that most CNS lymphomas, primary CNS, they have MYD88 and CD79B mutations. Those are the main mutations that you're going to see in those. And it looks that they are common in these lymphomas that involve immunoprivileged site, the predominant one being the CNS and the testes. So these type of alterations are common in that context. This is another paper here showing the evolution of the clonal evolution of CNS lymphoma, and you can see that CD79A and MYD88 seem to be early events in addition to P16, and that the tumors that have CD79B mutations apparently seem to have a better overall and progression-free survival. Also, PD-L1 expression, which is being tested in many different tumor types across the body, seems to be present in about 30% of these tumors, at least in this publication. Moving on to case number 2. This is a 60-year-old man with increasing headaches and dyspraxia. And the MRI showed an irregular contrast-enhancing mass in the right posterior temporal parietal lobe adjacent to the ventricle. That is also something that is often a clue, that is adjacent, deep adjacent to the ventricle, the periventricular region. And this is a slide. And this is a case, I might have shared it in other presentations, that is remarkable because it really take your time. You have to take your time with it to reach a definite diagnosis. These are often problematic. What you're seeing is you do have quite a few scattered reactive astrocytes that, with some atypia even, that may make you think of some sort of glioma or glial process. You also have macrophages. Numerous macrophages in this context. You have some perivascular cells. As I mentioned to you, lymphoma is angiocentric, likes to hang out around the vessels, particularly infiltrate the vessel wall. So you have to look at this infiltrate very carefully. And we are seeing it, and in most of these cells, actually, they are tiny. They're small lymphocytes. So this is okay within many different reactive processes. So in a case like this, deep lesion involving the periventricular region, something that you have to think about is demyelination, demyelinating disease, like multiple sclerosis. That certainly can give you a pattern similar to that. What is different here is that you don't have a very good sharp border. You have these patches of macrophages that mix with different cell types involving the biopsy. So that is a little unusual, but it's something to really have in mind. And again, you have more of these. Small lymphocytes, perivascular, and also more here even. So you have to look very careful at these vessels, and you see that the lymphocytes are small. But it pays to look very carefully around the biopsy. Because if you go into certain area, and there was this corner, hopefully you took your time with it, you start seeing these large neoplastic lymphoid cells. Just a few scattered here in a corner. So this is a very illustrative example. This is very concerning. And I see a few stains. This is your CD68. Okay, numerous macrophages. So it confirms that you have an excess of macrophages in this biopsy. And that is important to have in mind. If you're concerned, let's say, look at here, many of them are really perivascular regions, resembles a lot what you see in demyelinating disorders. You have sheets of macrophages and many of them aggregating around vessels. So it is really valid to consider strongly demyelinating disease in this case. It's one of the cases that most closely resembles that. So, and when you have something like this, again, one of the traditional teachings in neuropathology is that you have to stay away probably from a diagnosis of malignancy or at least of glioma. So if you have even some reactive looking astrocytes there, you may be tempted to say, well, it's a deep mass, and even the clinical impression maybe could be a primary glioma or a high-grade glioma. You have to be very careful when you have that amount of macrophage to go in that direction. So, and here I don't have a CD20, but it was positive in those areas. So those large cells were actually large neoplastic B lymphoid cells. So the diagnosis here is large B-cell lymphoma with an associated macrophage-rich lesion. And something that was really relevant in the clinical history is that the patient prior to biopsy received corticosteroid administration. And this is a well-recognized phenomenon. After even a single course of corticosteroid treatment, you can have in the biopsy complete disappearance of the neoplastic process. This happens with large B-cell lymphoma. It's very sensitive to steroid administration. And as you know, if you work a lot with neurosurgeons, this is used a lot for patients that present with masses in the CNS. It really alleviates a mass effect of different masses. So if they have a broad differential, they may need to do that before even the patient goes to biopsy. The idea is that if they really are suspecting a lymphoma, they shouldn't do that. But it happens still. And it's something that you have to have in mind that after steroid administration, this is the pattern that you see. You can have complete disappearance of the CNS tumor almost. And the pattern that you see is that of macrophage-rich lesion, may mimic demyelinating disease, and oftentimes you can have a lot of apoptosis also. We didn't see that much in this case, but the presence of apoptosis and a macrophage-rich infiltrate is typical of treated lymphoma and may obscure the diagnosis in specific instances. So just something to really have in mind. I don't suggest the diagnosis of lymphoma even if I'm concerned about it, because you need to really see the lymphoma in the tissue sections. But it's something worthwhile talking and discussing maybe with your clinicians indirectly. That is one possibility. But that if the patient receive corticosteroids before biopsy, this can be the culprit. Moving to the next case, this is a 50-year-old woman with multiple cerebrovascular accidents and neurologic deficits, progressive neurologic deficits. And this is the imaging. So this is a FLAIR image, and you can see many different sections here showing these hyperintensities scattered bilaterally throughout the brain, cortex, white matter. And this is what's called a diffusion sequence, which is bright in areas and is very sensitive for detecting acute infarct. So there is evidence of ongoing acute ischemia, and some of them are recent. And again, small biopsy, right? Looks fragmented, seems to be. And part of stereotactic biopsy, that's again not uncommon with these lesions are suspected. And most of it, you have white matter, but you start seeing areas like these that are very suspicious. You can see vessels and you can see something in them. Only inside vessels. Again, large cells, not different from what we were seeing. Maybe a patch of perivascular chronic inflammation in areas, but really these small vessels are containing something that shouldn't be there. And even smaller here, you almost see a single filing almost inside these vessels. This is a very representative case that we saw recently. Again, here is a branch. You can see that this increased cellularity inside vessels. In the past, this entity was felt to be of vascular origin, but after the advent of immunostaining, we now know what it represents. And again, this is your CD20. And you can see that it's unquestionable large B-cell lymphoma, and in particular, it's an intravascular lymphoma. It's a disease that historically has been diagnosed mostly in autopsy, and that may be the case in some instances, because they present with a medical type of prodrome like that, neurologic disease. It can present with a rash as well, involve the skin. Sometimes a skin biopsy can be helpful. In this case, the patient actually did have some skin biopsies, but they were negative. They can involve the lung. So it presents mostly as a medical problem, not a neoplastic problem. So that is something you can see here. This is amazing how you can see it as a single cell level. You can see how it is involving almost a capillary probably. So this is actually something very important to have in mind. This one is a good example, but I tell you, I've seen some cases in which you only have fragmented tissue in one single vessel with some rare cells that may show up in a level. So if you're suspecting this, or if they're suspecting this from the clinical side, and you have a biopsy that looks normal, you really have to do step sections and try to see it. And I've been there and being close to miss it, actually. And again, this is really a medical urgency because the patient's continuing declining, actually, and you may get the autopsy eventually. So it's something that it's important to have a high level of suspicion for this. And sometimes, even if you see something, a vessel that looks funny, throwing a CD20 it's not a bad idea. But you see here, you even have more B cells and you can see that they're exclusively inside small vessels. So the diagnosis is intravascular lymphoma, large B cell type. It's important even before you have the stains, if you feel very comfortable about the diagnosis or you have a very big suspicion, to really communicate this with the team so they can at least start planning on the appropriate treatment. Case number 4, 30-year-old woman with headache and blurry vision. And this is the MRI, T1 weighted post contrast. So you have several enhancing lesions. This one has a ring type of pattern, so it suggests that you have central necrosis. They are deep, multiple. Okay, it looks like it has one of the images disappeared, but I have the H&E here to go. For a moment, it looks like sometimes some of the cases, scan cases, disappear. This is actually the H&E slide that I scanned. So it's always good to have a plan B. And this is exactly the same slide that you have, that you may have access to. It may just show up later in the system, but okay. So you are seeing again some patches. Then see infiltrate again, small biopsies. Many of these are small biopsies. And here are some of the areas. And you do have an infiltrate that is concerning, but has a mixture of cells. Some of them are slightly plasmacytoid. You do have even some that appear to be plasma cells as well. And some that are a bit larger. This is CD20, which is really helps you a lot. And you see it again, unquestionable infiltrate of large lymphoid cells. It's slightly more heterogeneous than the cases that I showed you earlier, right? But you definitely have a neoplastic large B-cell component here. So the CD20 here is very helpful. And this shouldn't be reactive, right? Large B cells. And this is EBV. So in situ hybridization for EBV. And you have a strong positivity and then infiltrate. So here you have your diagnosis. You have two stains that are basic here that are helping you. There's the CD20 and the EBV. So the diagnosis, this is an EBV-associated lymphoproliferative disorder, and it corresponds to large B-cell lymphoma. So what are the clues that this may be EBV-associated or they may be associated with immunosuppression? First, the heterogeneity of the infiltrate. You see you do have a mixture of some plasma cells and smaller and larger cells. The infiltrate is usually more heterogeneous in these EBV-associated tumors. The presence of a ring-enhancing lesion, necrosis, these tend to be more necrotic than your sporadic, form large necrotic masses compared to the sporadic, to the lymphomas that are not EBV-associated or immunosuppression associated. In the presence of plasma or plasmacytoid cells, it's often a clue in the CNS, at least for EBV-associated lymphoproliferative disorder. So, and yes, it helps to have a history of immunosuppression. This patient did have it. So that makes it a little easier. It raises your level of suspicion. The patient was HIV positive and actually was being treated for cerebral toxoplasmosis, but developed some new lesions that were not responsive to treatment. And then the patient went for biopsy. So something also, a caveat here is that sometimes you can have a lymphoma, you can also have an associated infection. Sometimes you can have toxoplasmosis or something else, TB, in the same biopsy concurrent with your neoplastic infiltrate. So because you have one diagnosis and an immunosuppressed patient, doesn't mean that you have to forget about the other things. This one, we did a few stains for bugs. They were negative. So we left it as EBV-associated lymphoproliferative disorder. Something else to have in mind in these cases is that the immunosuppression may not be apparent immediately to you. I have had several cases in which you have this and you suggested, you test it and tell, the patient has this. No, they say, no, the patient doesn't have any immunosuppression. And they go back and do an HIV test, or they do a bone marrow biopsy, and they find something that can explain an immunosuppressive state. This is something to have in mind. Another clue also that you have to at least start considering immunosuppression is that when you have CNS lymphoma, if you are convinced of CNS lymphoma in a younger patient, most CNS lymphoma that we see are older patients. I saw you several cases, 60s, above 60s, 70s, 80s. That's when you tend to see primary CNS lymphoma. If you have young patients with something that appears to be CNS lymphoma, you have to be suspicious that immunosuppression is one possibility. And you do also to have in mind, you can have many different type of the spectrum of immunosuppression associated states. You can lymphoid proliferations, you can see them. This one, the next case here, I'm showing another example of EBV associated lymphoproliferative disorder that I didn't scan, but I wanted to share with you. This one actually has an even more heterogeneous infiltrate. Plasma cells, small lymphoid cells. This was a bit more tricky to diagnose. So a very heterogeneous infiltrate. A few eosinophils here and there. Few larger cells. And this one had a few recut sections, but let me show you this is the CD30. So this was actually one of those that are Hodgkin-like, which is one of the morphologies that you can see with EBV-associated lymphoproliferative disorders. And this one was, in some areas, was focal, but it did have Hodgkin-like cells in areas, probably in other sections. So something to have in mind, that you can have the spectrum of lymphoproliferative disorders. Most of the time, what you're going to see is a large B-cell lymphoma that has a more heterogeneous infiltrate. That's the most common thing that you're going to see. But these even rarer examples of immunosuppression-related lymphoproliferative disorders can be present, and so you have to have a high level of suspicion particularly when you have that history of immunosuppression. The patient is suspicious for it. Okay, moving into the next case. The next one is a 63-year-old male with diagnosed with an intraparenchymal hematoma by imaging on CT scan, and had some unusual features, went to biopsy. Case number 5. And this is what you have. You know you're in brain. That's the main thing to know. You can see here that you have brain parenchyma here surrounding these pink blobs. Gliosis, maybe rare lymphocytes around vessels, reactive astrocytes, again surrounding these. Nice reactive astrocytes mostly. Just rare, a few plasma cells here and there. Okay, so here, this is not something that you see in the brain very often, so you probably will start doing a few stains. In a case like this. I can tell you that it was Congo red positive, so it is it's composed of amyloid. Probably, I'm sure that you suspected it just from the H&E. And this is a dual stain for kappa and lambda, with lambda being red. So it has a lambda predominance. And that is often the case with these amyloid, tumefactive amyloid depositions in the CNS. And probably at other sites, it tends to be lambda rather than kappa. Kappa will be brown, so this is a dual immunostain. You have a trace of little brownish stuff, but it's really lambda restricted. And you have, this is, let me see, the CD138 highlighting a component of plasma cells, which these represent usually, of course, you need a more wide systemic workup in a patient like this, but this is frequently a localized amyloid deposition. It's a clonal process. The plasma cells are also lambda light chain restricted, so you have a clonal focal process of lambda restricted plasma cells that are responsible for this amyloid deposition. These are usually very indolent. They grow slowly. So, and they may require treatment. Some of these patients have been treated with radiation, and they seem to respond sometimes. So they may even need to be treated as what they are really, localized neoplasm, but they are very slow growing. Now with available technologies, you can test for these more objectively with mass spectrometry, which is used for the identification of amyloid depositions, and the CNS and other places. So it's something to have in mind. And again, this is a light chain amyloid type. You know that amyloid deposition in the brain, you see it in the context of Alzheimer's disease and amyloid angiopathy, but the amyloid is different. That's alpha A beta amyloid. So the amyloid that you're testing here are different. These are localized amyloid aggregates that are actually light chain related. So I end up calling these amyloidomas to make sure that it's understood that these are really is amyloid deposition related to a tumefactive form of amyloid deposition. You can call it AL, localized amyloid, or whatever. Of course, the idea is that from the clinical side, they have to make sure that the patient doesn't have another systemic process. But in my experience, many of these, the pure amyloid forms, are really localized forms. You can have also other light chain type depositions, and studied those in the past, and the CNS that can be non-amyloid in origin. Many of those are actually kappa light chain residues. You can have crystal storing histiocytosis. You can also have light chain disease, light chain deposition disease that is not amyloid in nature. So and in those cases, again, mass spectrometry, now we know that it can be applied for formalin fixed tissues and has been a great tool on characterizing these depositions. Next case is a 50-year-old woman with a sudden onset of quadriparesis and an epidural mass in the spine, kind of high up in the interface of the cervical and thoracic levels. Well, this is really playing with me here today. Let's see. They're kind of popping in and out. We may have some problem with the server or something, but again, we can go to the H&E I have. So this is the infiltrate. And of course, we're in the theme of hematolymphoid proliferations, and that will be what you suspect in this case. It's relatively monotonous. And the first impression when I got this, being focused in the CNS, is, probably is a large B-cell lymphoma. And we stained for that, but we were wrong. That was a preliminary impression. Then the next step is to start characterizing. So once you know it's not a large B-cell lymphoma, then you do have other things that can happen. This one is not in the CNS proper, so you can get any type of lymphoid process that affects the human body can happen there. So it's something to have in mind. But you do a relatively monotonous proliferation. This one had the main stains that were positive here were CD43. That was the strongest marker that was most strongly expressed, uniformly expressed. CD43. KIT. We have KIT also expressed here. And there was also a small population of, this is CD33 also, which was a little weaker, but positive. Myeloperoxidase was actually kind of weak. So, and let me see what else we have from the report. So they were negative. The neoplasm was negative for CD3, CD20, CD30, CD31, CD45, CD138, PAX5. You can tell by now that HemPath was involved, and this is given the number of stains. But this was really an unusual situation. Myeloperoxidase was focally positive. Same cell, and the cells was also negative for CD7, CD123, CD34, CD56, CD68, CD163, lysozyme, TDT. We did also other things that we wanted to exclude, OCT34 for a germ cell tumor, melanA. So we were in the uniform agreement. This was an hematolymphoid process, and there was more of the myeloid lineage. So the diagnosis was primitive hematopoietic neoplasm and was more consistent with the so-called myeloid sarcoma. This was, my understanding, was a single mass There was nothing, but of course, this patient merits more systemic workup for it. But this was the real presentation of this. So something to have in mind, that when you have something that looks lymphoid, it's negative for your traditional markers, try to think about myeloid sarcoma, which can occur at any extramedullary site, including the CNS and its coverings. Next patient, 60-year-old man with a decreased productivity at work and slurred speech for 2 months. Imaging showed multiple enhancing lesions in the right frontal lobe. And of course, even at low power, you must start thinking, well, this doesn't belong in the CNS. This looks like a lymph node at low power. So I think we're in the right camp here. And if you go at high power, certainly there is a very atypical proliferation. Very concerning. Probably if you do some heme path, you may have start seeing these cells may start catching your attention about possibilities. This was another one that we started with a CD20 and B cell markers, and they were negative. Things like this and things like that. So probably you're suspecting something already. Definitely neoplastic, and definitely hematolymphoid in origin. So that's something we at least can start there. And then we get, of course, the help of our hematopathology experts to characterize it further. Okay, so this is the H&E. You wanted to just give you a flavor around of the lesion. Let's see what immunostains we have. So the tumor was MUM1 positive. This is MUM1. CD4. But then was negative for a lot of the other T-cell markers. It was negative for ALK. The two stains that were actually also critical were CD30 and CD15, which was co-expressed by the neoplasm. It's both CD30 and CD15. This was something to have in mind. So actually, this was a very tricky case that ended up surprising me at the end. So it was placed in the category of peripheral T-cell lymphoma NOS. And if we can go over the other findings here, there was a variety of stains that were done. But I particularly was concerned about the possibility of Hopkins. Hopkins is very rare in the CNS. I've seen it maybe once or twice in my career. So involvement of that, if you think about that, you have to start thinking about excluding other possibilities. So here, the diagnosis of, as happens in other sites, of Hopkins and anaplastic large T-cell lymphoma, which is actually more common. You can see that in the CNS. That was another possibility. But there were things that were odd for it, where even the morphology, even though some of the morphology clues were suggestive, the co-expression of CD30 and 15 will be very rare in that context. And also there was a lack of TIA1 and lack of EMA expression. There were a couple other things. So it was, at the end, the uniform agreement that probably this was more in the peripheral T-cell lymphoma NOS camp. Peripheral T-cell lymphoma diagnosis in the CNS is very difficult. And something that we see in our experience is that many of these patients, they end up having multiple biopsies actually before you arrive at that diagnosis. So sometimes you start seeing something that looks more inflammatory. You are unable to completely clinch it, and may need repeat biopsies to make the diagnosis. That's in contrast, of course, to the conventional CNS B-cell lymphoma, which is relatively easy diagnosis once you think about it. So and here, of course, this one had a T-cell rearrangement, but many times T-cell rearrangement, positive T-cell rearrangement, I've seen that not uncommonly in the CNS, even in reactive processes. So having a single result of that doesn't equal lymphoma. It's very similar situation that you have in the skin. You can have these localized clonal proliferations that will eventually go away, and it's not really wise to make a diagnosis on one. If you have a persistent clone, if you start seeing progression and all that, of course, you have to start going more in that direction. But the main message here is that peripheral T-cell lymphoma is a very difficult diagnosis in the CNS, and you have to approach it with caution. So, and this was actually a good morphologic example. You have some that may have less atypia, that may be more of these really what you classically see as a peripheral T-cell lymphoma, of cells that are medium size or even smaller, that become even more difficult to diagnose as lymphoma. Case 8, this is a 61-year-old man with a history of Meniere disease and had an enhancing lesion in the right lateral ventricle. And this is interesting because you do have some residual choroid plexus. Also something that was, to me, very fascinating. You have all these almost cholesterol type clefts almost in some lesion. And then this proliferation of small lymphoid cells. There were a few plasma cells as well. Very dense, so you can see this is concerning. Very dense proliferation. You have scattered small lymphocytes and plasma cells. And pretty much a few larger lymphoid cells. And again, a lot is fascinating how you have these probably intramural, all these spheroids, probably part of the choroid plexus, being infiltrated and just surrounded by this sea of small lymphocytes. Okay. Here are some immunostains. The main one I have here for you is, before we go into the immunostain, the patient, some of the material was sent for flow cytometric analysis, and something we had to talk about. And the result was low viability sample in maybe a minute kappa restricted B cell clone. and the polytypic background cannot be excluded. So, and was interpreted as no having a definite evidence of a lymphoproliferative disorder. One advice about doing flow cytometry: in most instances when lymphoma is suspected, I do not save sample aside for flow cytometry. And again, in the vast majority of cases, the main thing is that the most primary CNS lymphomas, as we saw earlier, are large B-cell lymphoma. Their flow cytometry is less useful. You can do all that. You can make your diagnosis very easily with immunostains. And remember that you do have very small biopsies coming. So, and the infiltrate may be patchy. So you may actually be stuck without a diagnosis with an inconclusive flow cytometry result and really no morphology to evaluate. So in those instances, for the most part, it is not useful to apply flow cytometry. The exceptions are, yeah, you're suspecting T-cell lymphoma, maybe the patient has had a third biopsy or something like that, and you are suspicious of it, and you want to prove it a little bit better. Or in cases like this, in this case, many times it helps, but you see it was fibrotic in part, and it didn't help very much. But if you have these dense, small lymphocytic proliferations involving extracellular sites where you might have a big piece, certainly you can consider doing, in those cases, flow cytometry. So, but we have here one, even in that case here, we had one that was inconclusive. This is, again, a dual stain for kappa and lambda. And in this case, you do have a lot of brown and no red. So certainly the impression that was picked up, there's a few red cells, so it did work, but you have really kappa excess. So in this case, we were able to confirm that that clone that was suspected from the flow cytometry was indeed real, and this is actually a lymphoma and not a reactive process. So the diagnosis was low-grade B-cell lymphoma, and we were favoring extranodal marginal zone lymphoma. So we talked about CNS, primary CNS lymphoma. When it occurs, the classic primary CNS lymphoma that involves the brain parenchyma, again, I'm emphasizing this a lot, but it's important, it's a large B-cell lymphoma. But you do have also another presentation, which is this one. These are extranodal marginal zone lymphoma. When involving the brain, presents typically in an extraaxial location as a single mass. These one occur inside the ventricles. Classically, they occur in the dura, and they are almost indistinguishable by imaging from meningiomas. So many times what happens is when you see it in frozen section is that they come with a diagnosis of meningioma and they take it out and you call the surgeon back. You say, no, this looks like it may be lymphoma, and they just completely are completely incredulous because they really feel that it was going to be a meningioma. They present as a distinctive mass in the extracellular site. So we have a very dense lymphocytic proliferation in an extracellular site. If you have enough tissue, if you're in a frozen section setting, try to send a little piece for flow cytometry if you can. Sometimes it can be helpful, but it really save a lot for immunostains. The differential diagnosis, you do have some reactive processes that occur there, so you have to have that in mind. You also can have a lymphoplasmacytic variant of meningioma. That is one of the rare subtypes. But in those cases, you really have to be convinced that you do have a neoplastic meningothelial component. So those are the issues that you have to have in this context. Case number 9 is a 73-year-old man with a right temporal lobe mass. And here you do have normal choroid plexus. It's something to be well aware, important to recognize in biopsies, because sometimes it can be misleading. It has calcifications and can be mistaken for tumors and other things. So it's good to be acquainted with the normal morphology of the choroid plexus, frequently calcified with age. And then you have something like this here, this NES. is an infiltrate. It has an associated desmoplastic response. Desmoplasia is frequent in lesions that involve the extraaxial compartment of the CNS. You don't see it inside of the brain, but you see it in the coverings, inside the ventricles or outside. And this is what we have here. So you have an infiltrate that is very concerning and very nested. And we did a variety of stains, of course. In this case, there was nothing in the history that was helpful. And this is cytokeratin. This case is a little bit crushed, and my impression is that the stains didn't work very well, but we had some evidence that there is some. This is cytokeratin A1A3. And this is cytokeratin CAM 5.2. Most of the other stains, P63, P40, CK720, etc., didn't work very well. So actually, we just call it involved by metastatic non-small cell carcinoma. We weren't able to characterize it further. The main thing to have here in mind, moving into secondary metastatic tumors, is that here the differential, of course, which it was attempting one, is choroid plexus carcinoma, particularly if they tell you, well, the patient doesn't have any primary elsewhere that we know of, or they did a pan CT scan and they didn't find anything. And that is a temptation that very often leads to a mistake. For practical purposes, and that is my belief, choroid plexus carcinoma does not occur in adults. I mean, this is, for me, I know that there may be exceptions. You may have patients with a syndrome, or you may have case reports out there of convincing cases in which it can have happened. But metastasis being so common, and choroid plexus carcinoma by itself is a really rare diagnosis, even in the right setting. So being such a rare disease, and a disease that really predominantly occurs in very young children, making that diagnosis is really essentially most of the time you're going to be wrong. So in a case like this, it's very tempting. This was a lesion that was infiltrating choroid plexus. It looked like a carcinoma. We didn't even raise that possibility in the differential. We really call this metastatic carcinoma, and that's just really something to have in mind. And the converse is also true. If you have a 2-year-old with something that looks like a carcinoma, raising the possibility of metastatic carcinoma is also much less likely than having a primary choroid plexus carcinoma. But just by age, it's a very helpful indicator in this context of when you have a malignant epithelial neoplasm involved in the brain. So here, again, we were nondescript. I don't know what the patient ended up having, but it's something just to have in mind that you can make the diagnosis of metastatic carcinoma even in the absence of a true primary. So it's really then the ball is back into the court of the clinical team to make sure that they really scope and pan scan the patient very well. Moving into the last case, 76-year-old woman presenting with possible seizures. And this is your scan. It's a coronal T1 weighted image post-contrast, and you can see well-circumscribed mass, extraaxial, meaning outside of the brain, with a very nice dural tail following the falx, a smaller one probably following the convexity. And then you have an extension here through the calvarium into the scalp almost. And of course, we do see these with meningiomas that are aggressive. So it's something, it's a typical, and that will be here the main consideration. every time you have something like that, a dural base mass with dural tail, let's say 95, 98 times, 98% of the time will be meningioma. And this is what we have. And certainly you have areas that are classic meningothelial. Here's a meningioma. You have a syncytial pattern of growth. That means you're not seeing, the junctions are so tight that you're not seeing the cell borders. Cells are oval to round. You do have a suggestion of whorl formation. So in most instances, this is not a difficult diagnosis. But what's unique? Let me see if you have some other areas with whorls. So you definitely have a meningioma. What is unique is this here. And this is different. Can you have glandular differentiation in meningiomas? Yes, I mean, there have been some reports out there, but this is more than that. You have necrosis, you have malignant appearing glands, and in this case, the history was helpful. The patient has a history of duodenal adenocarcinoma with widespread metastasis in the abdomen and bones. So this is really the phenomenon that you can see sometimes of metastasis from tumor to tumor spread, basically. So this is a metastasis of a duodenal adenocarcinoma to a meningioma. The meningioma is actually one of the most frequent recipients of metastases in the neoplastic world. And it makes sense. A meningioma is very vascular, and they can grow slowly for decades. So it makes it a nice host for tumor to tumor spread when you see that. So the most common tumors that you see in that case is breast to meningioma. That's a classic one that we see. This one was a bit more unusual, but unquestionably it represented a metastasis to a meningioma. So metastatic adenocarcinoma involving meningioma, and it was duodenal primary, the culprit. Okay, so I think this is all the cases that I have for the moment. Again, there's a lot to metastases and hematolymphoid neoplasms. Just really, there's also the phenomenon that we're seeing more of treated metastases. Metastases in the CNS are being treated more commonly now, even before biopsy with gamma knife. And sometimes you get resections after that, after growth, in which you can have a mixture of treatment effect and metastases as a phenomenon that we're seeing more often now. There's a lot of important biology being studied of the tumor microenvironment and metastases. So it's a very fertile area of research at the moment. But again, didn't have time to cover all that. Just wanted to show you a few illustrative and interesting cases and for stimulation. So, and we'll move into the questions now. We can start with question number 1. Amyloidomas in the CNS are usually composed of A, AL amyloid kappa light chain restricted, B, AL amyloid lambda light chain restricted, A beta amyloid, transthyretin, or microglobulin. Okay, so I am we can move on. The actual answer is AL amyloid lambda light chain restricted. As I mentioned, you can have other depositions in the CNS that are not amyloid that tend to be kappa. A beta amyloid is the amyloid that you see deposited in Alzheimer's disease. It's not tumefactive. It's part of the plaques, and also you can have it as part of this amyloid angiopathy. And of course, the other ones don't tend to be an issue in the CNS. Question number 2, a 30-year-old man presented with headaches. An MRI demonstrated a dural-based mass with a dural tail. Again, a classic imaging finding of dural-associated masses, predominantly meningiomas. Histologic section demonstrated numerous lymphocytes and plasma cells. The most likely diagnosis is you have a few minutes to respond.
Yeah. I see a few A's, like A, that is diffuse large B-cell lymphoma. Let me see if there might be more options. Many are talking about B, that is extranodal marginal zone lymphoma.
And that's actually the right answer. So again, remember that the primary CNS lymphoma mostly involves the CNS parenchyma around the ventricles. They form deep in many and sometimes multiple masses. But when you have this extraaxial mass that mimic meningioma, the classic scenario is a low-grade B-cell lymphoma, and extranodal marginal cell lymphoma is the predominant culprit in that case. They tend to occur also in younger patients compared to diffuse large B-cell lymphoma. So it's just something to have in mind when you have a biopsy that comes to you, particularly in the setting of intraoperative assessment, that they tell you it's a meningioma, and you see it, you have a sea of lymphocytes, small. This is something that you have to have in mind. So question number 3, mutations in which of the following genes is more frequent in primary CNS lymphoma?
I think we can see some opting for E, that is MYD88.
And that is the answer. Is one of the most common alterations. Remember, MYD88 and CD79 are the two genes that are most frequently involved. So it seems to be part of the the other genes are less often affected. They're not. This is the main culprit actually. The final question: administration of corticosteroids pre-biopsy CNS lymphoma is likely to result in cytomegaly, glial atypia, macrophage infiltrate and apoptosis, superimposed infection, or tissue necrosis.
I see answers C, that is macrophage infiltrate and apoptosis.
And that is correct. There's a pattern that, again, you have to have in mind. The macrophage infiltrate may resemble demyelination. So something to really have in mind after these lymphomas are treated. Oftentimes, you may have a little bit of the lymphoma, still residual lymphoma there, that allows you to make the diagnosis. But again, it can really obscure the diagnosis. And it's just something really to have in mind. A relevant question to ask: did the patient? They may tell you the patient is suspicious for lymphoma. The clinical presentation many times is typical, and you want to ask, if you don't see it, that did the patient receive steroids? And that's something that is very easy to ask and to receive as a part of the information. And again, something to an important thing to have in mind in the evaluation of primary CNS lymphoma and pathology. So that is it. And again, we have reached the end of a very entertaining and long journey for me, which was this year. The different topics on CNS that were covered. I really hope that this has been helpful to you. And it's not going to be the end of it. So this was actually, I wanted to go systematically through these topics. There's a lot of things changing in CNS tumor classification. The WHO will be coming at some point sooner rather than later. So my idea is I'm going to space this a little bit more, maybe every couple of months is my plan right now, to cover different topics of interest, maybe new things that are relevant to classification, but always with the emphasis on diagnostic histopathology. So that will be the main emphasis of this series. So we, of course, with some relevant new things to be added to that in the ancillary testing arena. So feel free to suggest topics to us that you think may be of use, and we definitely will have that in mind. But the case-based format that we've been using, I will continue to use it in future presentations.
There are a
And
couple
we
of
have,
questions,
of course,
Dr. Rodriguez. Do you have a minute? So there are a couple of questions that you might like to answer.
please.
So Minesh from India, he has two questions for you. One question is, how to diagnose lymphomatous cerebri in a biopsy? And the second question is, please throw some light on vitreous aspiration biopsy in lymphoma.
So the first one is lymphomatous cerebri, and that is a term that is more clinical rather than pathologic, right? So what you are probably referring to is some sort of diffuse involvement of the CNS by lymphoma, and certainly that can happen. Something that we didn't go the classic large B-cell lymphoma involvement of the CNS. You do have more sheets of lymphoma, a perivascular pattern or infiltration of the vascular wall that's very characteristic. But occasionally you see examples of large B-cell lymphoma infiltrating at a single cell level. And that is sometimes difficult to distinguish histologically from a diffuse glioma, which you will see more commonly. So that is sometimes a differential that happens. I'll tell you, if you start seeing something that you're considering a glioma, and you have prominent nucleoli or cells that look a bit more rounded or elongated rather than astrocytic, that's something that at least should encourage you to do a CD45 or a CD20 marker to exclude that. So it does happen. It's a rare pattern, but it's something really to have in mind, particularly in small biopsies. And I think that's what you probably referred to about you have to just have a high grade of degree of suspicion and throw that marker to it if you're considering that. And the second question again was? Hello? Yeah, I didn't get the second second question. I think we lost communication or something. Hello? Well, it looks like we lost communication here. I will take a look at the Facebook page and try to answer some of these questions if they are posted there. And so happy to do that. Just be a little bit patient. But again, I will be seeing you frequently. You know, again, maybe every couple of months we'll try to have some topics of interest with interesting cases and with scan slides for your preview. So thank you very much for attending this lecture series, and it's been a pleasure and an honor for me to be able to deliver some and try to share a little bit of the experience that I gather from surgical neuropathology. Thank you.
Thank you so much, Dr. Rodriguez. Thanks so much. We really appreciate your time, and it has been really enlightening series for all of us, which has spanned more than a year. And thanks to all our viewers who have joined from so many different time zones. And as Dr. Rodriguez mentioned, that we have formally concluded this series of Neuropath from Dr. Rodriguez, but you would be happy to hear, as he mentioned, that he would come back and have lectures on relevant topics from time to time. So you are obviously not going to miss them for a long time, but it would be, but that this series at least, I mean, has come to an end, and it has really been a great pleasure to host you, Dr. Rodriguez. And you would also be so happy to know that today we had viewers from at least to more than 20 different countries who defied so many different time zones and listen to you. And a special shout out to our viewer from Bosnia, whom I haven't seen before, Faris. And from Greece, I saw today Sofia, and Ali has joined from Iran. And thank you, everyone. And thank you, Dr. Rodriguez. And once again, please subscribe to our YouTube channel, that is Pathcast, and also follow our Facebook page. And please subscribe to our newsletter by visiting our website, that is pathologycast.com. Thank you again.
Thank you.